Hi, this is Fred Page, and I'm presenting my final case study on my patient for the Lab Seminar 1 class. I started out with my patient presented with these symptoms of fatigue, fast heartbeat, worsening productive cough with yellow sputum, activity intolerance, wheezing, chest tightness with intermittent periods of shortness of breath, and frequent urination and dysuria. The subjective data of my patient was this. Mr. Crosby is a 60-year-old male who presented to the clinic today with complaints of fatigue, fast heartbeat, and a worsening cough with a yellow productive cough, activity intolerance, and wheezing for approximately about a week. Also, he reported some chest tightness with intermittent shortness of breath. Patient states that he woke up feeling tired and continued to do so as he began to get dressed for work. He continued to proceed to go to work, where he worked all day and where he experienced continued episodes of fatigue and activity intolerance throughout the day until his shift ended after 8 hours. And it was accompanied with frequent trips to the bathroom to where he had a burning sensation when urinating. His history of present illness, he states that he works about 8 hours a day with a combination of walking and driving a forklift. Reports that he works in an industrial manufacturing plant. He reports that his usual work routine consists of walking, but previously he had no issues, but here recently he started to feel more tired and unable to finish his work daily task. He does recall his heart racing as he continued to walk periods of time to where he felt tired. He remembers having a cough that started about a week ago and it began to produce yellow phlegm. He began to experience some chest tightness when he began to walk for an extended period of time, with some periods of inability to catch his breath. He also reported the frequent urgency to urinate and burning sensation when urinating. As far as his past medical history, he reported he has a history of high blood pressure and anxiety. He states that his overall health status has drastically changed over the past year since he elected to stop taking any of his blood pressure and anxiety medications. No childhood illnesses. As far as adult illnesses, he's the hypertension and anxiety. And he said, as far as injuries, he actually had a incident to where he was shaving in the bathroom back in March of 2010, and he had where he fell back and hit the side of his tub, and he was diagnosed with having a micro hemorrhage. And he, for surgery wise, he had a left total hip arthroplasty back in 2015. No blood transfusions. Immunization wise, he's had the flu, pneumonia, COVID 19 times 4 shots, and the measles, mumps, and rubella. No known drug allergies. As far as psych mental history, he has anxiety. No exams reported as of to date. As far as his home medications, he has propranolol, 12 milligrams, 1 tablet by mouth daily. Hydrochloride, 25 milligrams, 1 tablet by mouth daily. And amlodipine, 5 milligrams, 1 tablet by mouth daily. And far as family history, he reports a significant history of hypertension and congestive heart failure with his maternal grandmother, who passed away at the age of 91 due to a heart attack. His father is deceased, who passed away from heart failure during undergoing cardiac surgery to replace a heart valve and a hole within his heart. And his mother, who currently experiences high blood pressure and which is controlled by daily medication. No genetic defects. Deaths. His father is deceased with the cause of congestive heart failure, diabetes, and hypertension at the age of 76. His paternal grandmother is deceased from diabetes and congestive heart failure at the age of 91. His paternal grandmother passed away at the age of 92 with dementia. He's an African American male. For our social history, he's a regular laborer, forklift driver. His highest level of education known is high school diploma. Housing, he currently resides alone in a 2 bedroom apartment. Safety, he said he feels safe at home where he currently lives. Socioeconomic status, he said he's pretty much part of the middle class. He said he partially abides by a diet of a cardiac diet with low sodium, but he does deviate at times, taking in more salt than usual. As far as cultural beliefs and practices, he's a Southern Baptist. It is spiritual. Exercise, he reports he gets his exercise pretty much on his low stretches of walking daily at work. Sleep, he reports he gets about 6 to 8 hours nightly. And sexual history, he reports that he engaged in sexual intimacy with his girlfriend with the use of ED drugs, of Cialis. Drugs and alcohol, he drinks about 4 beers a day and a half pint of Hennessy. He said it takes him about 2 or 3 days to finish a half a pint. Social support, he reports that he has the support of all three of his children. Stress and anger management, he reports that his stress levels are high, so he attempts to compensate using alcohol. He reports the use of alcohol, attempts to relax each evening, so it's a daily use report of that. Recreation and travel, he said he doesn't travel, but he was a avid former softball and basketball player in no military service. For his the review of systems, general, he said report that he's lost about 10 pounds since he stopped taking his blood pressure medication about a year ago. last spring of 24. His skin was warm to dry to touch. His eyesight is bilateral, is suitable for nearsightedness due to his previous head injury of the microhemorrhage when he fell into the tub. He was instructed to wear glasses but has not attempted to get a new prescription in several years. He reported no hearing problems, as far as and denies the use of any false teeth or any oral problems. Cardiovascular wise, he reported the history of hypertension and congestive heart failure. He denies any chest pain. As far as respiratory wise, he did report the intermittent periods of shortness of breath upon ambulating, and also reported a 25-year smoking pack history with the use of cigarettes. And GI wise, no reports of nausea or GERD. GU, frequent episodes of urination accompanied by dysuria. And musculoskeletal, he had the total left hip arthroplasty back in 2015. And he had a general appearance. He was alert oriented times 4 with cranial nerves intact. He said as far as his pain level right now is 3 out of 10. His weight was 68.3 kilograms. His height was 61 inches. His BMI was 28.45. Far as history questions pertinent to this patient, what I would ask, it would be relevance to far as with pneumonia, pretty much is what I would state as far as his diagnosis. And that will coincide with, I would ask him about the shortness of breath, difficulty breathing. Do you feel like you need to cannot catch your breath, which is what he reported? And has the cough got worse recently? He said yes, because of the presence of the yellow sputum has become more productive. And of course, we know the color of the mucus is yellow, which indicative would be indicative of pneumonia, as well as the fatigue. We want to know for as exercise intolerance, which he reported the fatigue during presence at work, and that correlates with pneumonia as well as COPD. And also to we will ask, do you feel the need to stop and rest often? In which he reported because of shortness of breath, and he said the chest tightness was present with the shortness of breath, so that will coincide with COPD. And he stated that he woke up this morning feeling usually tired and worn out, which is not usual for him. But he said the past couple of days he did, and this morning was even worse as he presented to get up to go to work. And far as his smoking history would totally relate to far as a possible COPD exacerbation, because he has that 25-year smoking history, and as well as the wheezing was accompanied both upon um, assessment, and that would correlate with pneumonia and COPD. And the regular heartbeat would coincide with COPD as well as pneumonia that he actually did have. He said he had a fast heartbeat, and edema would be present. We would be relevant to know if there was any edema present, but it wasn't with him. And far as when it comes to pyelonephritis, the history question I like to ask on top of, he did report that he did have the discomfort and burning during urination. And as he reported he had the frequency to have to go to the bathroom, which he does. And pretty much would add to that, do you feel like you're urinating right away? Do you feel like you need to urinate right away? And as well as, is there any blood present in your urine recently? Along with the symptoms that he had, and that would correlate with the diagnosis of pyelonephritis. In terms of the 4 differential diagnoses that I would come up with him would be pneumonia, pyelonephritis, COPD exacerbation, heart failure. And those pretty much my hypothesis with that, starting out with pneumonia. The inspection, of course, the patient does present with shortness of breath and actually has, far as increased breathing with no sensory muscle usage, but he basically had dyspnea on exertion, as well as auscultation. Of course, he had those wheezing breath sounds and throughout his lung fields. And subjective wise, he did report the shortness of breath, intermittently, the cough, the productive worsening cough, and the wheezing and the fatigue. He did have it for a couple days, so say about a week ago. So basically, that would be a definite pertinent diagnosis, that will lead me to the diagnosis of pneumonia. And next one will be pyelonephritis. When it comes to far as pyelonephritis, the presence of, he didn't have any fever or chills or anything like that, that would signify far as a UTI, pyelonephritis. And far as he didn't report any flank pain The only thing is, and also to no abdominal tenderness. Only thing pretty much he just had was a dysuria and the frequent urination that he had. That would be for that. And then when it comes to COPD exacerbation, for as inspection, palpitation, COPD, he did not have any mild clubbing of the fingernails. He had the no accessory muscle usage either. He basically just had increased breathing, basically accompanied with dyspnea on desertion because he said he pretty much was accompanied with chest tightness. And as far as the breath sounds on auscultation was wheezing throughout his lung fields. And the importance of shortness of breath with activity, which he did report it because he said he was short-winded and he was unable to perform his normal work duties. And the persistent cough with mucus production would be indicative. And also to having a smoking history of a 25-year post-smoking pack history of with cigarettes. And in terms of heart failure, the inspection of shortness of breath and its increased breathing, and of course he had dyspnea on exertion would be for as he had inspection, and for as auscultation, the wheezing being present with indicative of fluid throughout his lung fields, and the report of shortness of breath, of fatigue, and exercise intolerance as he performed his job duties. The physiology of pneumonia. Pneumonia is a disease of the lungs caused by microbes, infections, and parasites. The contamination causes the lung air sacs alveoli to become kindled and filled with fluid and discharge. They can make it difficult for the oxygen to breathe and to enter the circulation system. And for its patho-wise, explores pneumonia pretty much occurs when germs enter the lungs and cause contamination. The immune system response to clear the contamination and aggravation of the lungs, which basically invasive to the alveoli, the air sacs. This aggravation can inevitably cause the air sacs to fill up with discharge and fluid, basically causing side effects of pneumonia. The etiology is aggravation of the lung tissue caused by the different irresistible microbes or infections or parasites. And the cause of pneumonia can shift depending on the individual's age, well-being, status, introduction to hazard components, and as well as the most common types of pneumonia is bacterial, viral, and microplasia. Microbes are a common cause of pneumonia in adults, and numerous microscopic organisms can cause pneumonia, but Streptococcus pneumoniae is the most common cause of pneumonia here in the United States. And in terms of the physiology for pyelonephritis, it's a bacterial disease that irritates the kidneys. Pyelonephritis, for the most part, is a complication of a rising urinary tract disease that spreads from the bladder to the kidneys. The pathophysiology of pyelonephritis results from a bacterial attack of the renal parenchyma. Microbes are often reach the kidney by climbing from the lower urinary tract system, and bacteria occurs mostly in all age groups, but can be asymptomatic and do not lead to disease. And bacterial components impact the advancement of the disease as well as the surrounding things that happen that cause pyelonephritis. The etiology of pyelonephritis occurs with the defilement of the pure-urethral range within a pathogen from the rectum. The microbes will begin joining the urethral mucosal epithelial cells and inevitably travel to the bladder. Their microscopic organisms must overcome the resistance and duplicate quickly to sufficient to permit movement from the ureter to the kidneys. Urinary tract contaminations happen more frequently in females due to their shorter urethras, hormonal changes, and nearness to the urethra to the anus. In terms of COPD exacerbation, the physiology of COPD is a constant irritation of the aviation routes and pulverization of the lung tissue, driving to the respiration obstacles and disabled gas trade. COPD occurs due to respiration routes and alveoli in your lungs end up becoming less versatile, and the dividers between the numerous of the alveoli are annihilated, or the dividers of the respiration routes end up thick and kindled, causing more bloody bodily fluids than usual and can end up clogging the lungs. the pathophysiology, COPD leads to mucus hypersecretion and ciliary brokenness, wind streams, obstacles, and hyperinflation, gas trade anomalies, aspiratory hypertension, and systematic impacts. The etiology of COPD is caused by a drawn out introduction to hurtful, harmful particles or gases. Cigarette smoke is the foremost most common cause of COPD around the world, and other causes may incorporate secondhand smoke, natural and world-related exposures, and alpha-1 antitrypsin insufficiency. And in terms it relates to heart failure, the physiology behind heart failure, heart deterioration is the pathophysiologic state in which the heart, through anatomy of a cardiac work, falls flat to pump blood at a rate that consummates with the prerequisites of the metabolizing tissues and can do so with the lifted diastolic filling weight. Patho-wise, the muscle compression of the heart may defibrillate due to overburdening of the ventricle with blood aidment diastole, and a cardiac anomaly pretty much occurs, causing systolic and or diastolic ventricular brokenness. Anomalies of the valves, stenosis, spewing forward, pericardium, endocardium, heart rhythm, and conduction, all those may start to fail when these begin to occur. Etiology, heart failure occurs when sudden or intense heart deterioration can be caused by harm or disease that harms your heart, a heart assault, or blood clot in your lung. And also to this, coronary supply route infection is the common cause of heart infection or heart failure. The illness begins to build up a greasy stores of within the valves of the heart, and the stores that limit the supply throughout the body diminish the bloodstream and causing the heart to experience an assault. As far as diagnostic testing, um, when it comes to pneumonia, nurse practitioner will want to order a chest X-ray or a CT scan. They pretty much will show the fields of the lungs up close and throughout the body, through a scan. And also too, you want to gather sputum samples, because sputum, far as the presence of green, yellow, or any type of discolored sputum sample, can be tested to see if actually the presence of any type of bacteria or viral pneumonia um, can be diagnosed. And far as terms of pyelonephritis, you want to do a urinalysis, and it does have to be a clean catch to where it cannot be contaminated with a previous container or anything like that. And also too, you want to do a urine culture with sensitivity when assessing the urinalysis. And also to a pyelonephritis, you want to do a CBC to see what it shows within the urine function. In terms of COPD exacerbation, the prominent thing would to be later. Initially, you want to do chest X-rays and CT scans to see how the lung is functioning, as well as with pneumonia, and as well as you want to do arterial blood gas. You'll be more concerned with the carbon dioxide level, see if it's increased, and see what their CO2, what their O2 level is, to see if it's actually decreased. So if their CO2 level is up at a certain amount, pretty much patients who suffer from COPD do have increased rates of carbon dioxide levels, and as well as they tend to have lower O2 levels. And with this patient, more likely he would probably had that result. And as far as a pulmonary function test, you want to do that as well after the fact on an outpatient basis, after the patient get well, pretty much to see what their lung function is, to actually to get certain values to be able to diagnose the patient with COPD, being that he's never been diagnosed. And as far as when it comes to heart failure, the blood test you want to do is a BNP to see what their heart function is, and as well as chest X-ray to see what the heart and see if there's any fluid, anything present. And also too, you can do EKG to see what the heart rhythm is, and an echocardiogram will be very good as well. It will be able to tell you how their heart function is, as far as their ejection fraction. That will be important to know in terms of the patient might be suffering heart failure. And also too, if it's pertinent, you can do a possible order of cardiac catheterization to be done once the patient gets to feeling better. As far as analysis, I say that my patient would be primarily diagnosed with pneumonia due to the complaints of fatigue, tachycardia, and the worsening productive cough with the yellow sputum being present. And as well as he's reported that he actually reported activity intolerance due to not being able to adequately take good deep breaths and being able to perform his work duties without feeling tired and not being able to experience without having a chest tightness present with the shortness of breath. And also, too, he said the wheezing, he pretty much heard the whistling noise that's been occurring for about a week. And a secondary diagnosis with the pyelonephritis, basically the UTI being at the presence of the urinary frequency that he reported and the dysuria, the burning and urine sensation that he was feeling. And also, too, lastly, would be a COPD exacerbation, which is highly possible. Really won't know until you actually do more testing to see, because all those primary complaints is similar to COPD as well as indicative of pneumonia. And the chest tightness with the intermittent shortness of breath will actually indicative to show you that it also could be a COPD exacerbation as well. Here are my references, and I do thank you for listening.